So like I said at the beginning, we will focus our topic discussion on liver-directed therapies with a focus on radiation oncology with hepatocellular carcinoma, but it can be used for other pathologies under the guise of liver-directed treatments, including cholangiocarcinoma and other metastatic disease. But we'll focus today specifically on hepatocellular carcinoma. So what I show here is an older depiction of the hepatocellular carcinoma treatment paradigm. This stratifies hepatocellular carcinoma based on their BCLC stage category, which is, a combination of the size and underlying degree of cirrhosis as well as performance status. And in the patients with small, singular tumors with good liver function and performance status, they're candidates for partial hepatectomy, as they have worsening cirrhosis or underlying cirrhosis or more multifocal tumors. They become candidates for resection as well as transplantation. And then as things start to evolve into more underlying cirrhosis and more larger or multifocal tumors, we enter the realm of liver-directed therapies. And I show this kind of older depiction to show that in this older depiction, those liver-directed therapies were called palliative treatments, and they consisted of TACE and sorafenib, and quickly morphed into best supportive care. But where does what I show below is a similar depiction of this flow diagram of HCC treatment, but work done by Laura Dawson's group in a review article, which is very pertinent to more modern day treatment. It dictates more role of our liver-directed therapies, including ablative percutaneous ablation, TACE, as well as where radiotherapy fits in, both in the definitive setting as a primary treatment for unresectable in patients not suitable for transplantation or other ablative modalities, also as a bridge to transplantation in patients that require that. In addition, it fits into the multimodality treatment of multifocal and large HCCs, or patients with more underlying comorbidity and cirrhosis, in combination with our colleagues doing TACE, sorafenib, and others. But still, in the world of hepatocellular carcinoma, the gold standard is transplant. As one of my mentors always kind of taught me, a patient has one liver but two problems: the underlying hepatocellular carcinoma and also their underlying cirrhotic changes and cirrhosis. And so transplant remains the gold standard because it solves both of those issues with one kind of procedure. But to obtain a liver transplantation, like we've heard in some of our other kind of talks, that you have to meet certain criteria and have certain disease characteristics that fit within those criteria to be successful in your liver transplant. And those criteria classically are the Milan criteria of 1 lesion less than 5 centimeters and 3 lesions less than 3 centimeters. Now, many patients might meet those Milan criteria for liver transplantation, but regardless, the issue still remains that they have to obtain a donor liver in order to get their transplant. And the way that the United Network of Organ Sharing organizes and administers livers is through UNOS points. Points are given based on the size, shape, the tumor, as well as the underlying MELD score of the patient and time on the transplant list. So when patients have small unifocal tumors and a good functioning liver with a low MELD score, they may stay on the transplant list for the greater part of 6 months or a year before they obtain enough MELD points to then get their liver. Now that can be somewhat nerve-wracking because during that time tumors can grow and become outside of the Milan criteria for transplantation, which opens up the opportunity for treatments with liver-directed therapy such as radiotherapy for bridge to transplant. So like I said, The rationale for bridge to transplant then comes into play while these patients are waiting for their UNOS points, and these extended wait times lead to the risk of becoming ineligible due to disease progression. Therefore, doing liver-directed therapies as a bridge is beneficial to hold the tumors at bay while we wait for eligibility for a donor liver. At the same time, there's also a bridging procedure and a downsizing to meet Milan criteria that is a very viable option for patients who are slightly outside of Milan criteria. Patients who have a single tumor greater than 5 centimeters or multiple with any one greater than 3 can oftentimes be targeted with liver-directed therapies to downsize their tumors and render them now eligible for liver transplantation. And here is just another example of that with UNOS has now accepted criteria which are considered acceptable for transplantation if lesions are successfully treated with bridging procedures and are stable. And people are eligible for MELD exemption points if completing these prior local regional therapies for 1 lesion greater than 5 centimeters but less than 8. For 2 or 3 lesions that meet the following criteria of each lesion less than 5 centimeters with at least 1 lesion greater than 3 centimeters or a total diameter of less than 8. Or 4 to 5 lesions, each less than 3 centimeters with a total diameter of less than 8. So this just opens up a very unique opportunity to bridge patients and downsize them and enable more patients to obtain this kind of life-saving therapy with liver transplantation. But despite our best efforts to downstage patients or obtain livers for transplantation, many patients are still rendered ineligible for transplantation. And in that kind of disease category, the liver-directed therapies come in as the primary or definitive treatment for hepatocellular carcinoma. And in the definitive treatment of hepatocellular carcinoma, a multidisciplinary treatment approach is paramount to optimal outcome. There are multiple different modalities which are tailor-suited to multiple approaches based on the size, shape, and tumor anatomy, as well as patient factors including logistics, travel, and preference. So things like radiofrequency and microwave ablation can be limited by location next to the diaphragm or great vessels, as well as certain sizes. Taste can be limited by high bilirubin, tumor thrombus, or aberrant vasculature. SBRT can be limited by underlying cirrhotic changes, as well as location next to bowel, and among others. This is just kind of an example that, of all these liver-directed therapies, the location and size and these multiple factors play a role in deciding what particular modality would be optimal for that individual patient. It's a very tailored and individualized approach to patient care, and hence the multidisciplinary nature being so paramount. So you might ask yourself, would you just get to the point and, where does radiotherapy fit in with the management of hepatocellular carcinoma in the definitive, bridge to transplant, and locally advanced settings? So the question many people ask is that radiotherapy seems like a relatively new development in the treatment of HCC. And that where was it in the early years as a primary treatment modality? Well, hepatocellular carcinoma is a radiosensitive tumor. It does respond well to radiation, and I present some data from Laura Dawson's group in Michigan showing that it's a tumor with a lack of a dose response. And, the holy grail of radiation is we give more radiation, we get more response, and more radiation is better. But the flip side of that argument is once the tumor has been ablated or the tumor is dead, it's dead, and that the increase in radiation dose leads to no extra cell kill and only increase in toxicity. So hepatocellular carcinoma as a tumor itself is very exquisitely sensitive to radiation and relatively low doses. And Laura Dawson's group showed this in a number of different cohorts, showing a very limited dose response to reasonable dose of radiation and quite high escalated doses of radiation. So the case being that hepatocellular carcinoma is very radiosensitive, but it has always been limited by the fact that it is within a very radiosensitive organ, being the liver. The liver has historically been very sensitive to radiation. And it wasn't until the advent of more modern therapies that we were able to treat liver tumors successfully. The way that radiation was done in the 70s and 80s was, without the advent of CT scans, and was done with fluoro and plain film imaging. And a radiation oncologist in the 70s and 80s would have taken a wax pencil and drawn on a plain film X-ray and created his radiation port in a very crude way, which they would have then poured a big lead block, hoisted into the head of a cobalt linear accelerator, and treated with a very limited beam arrangement to a large area of the patient's body. And that was preclusive of treating liver tumors because the liver is too sensitive to treat large portions of it to high doses of radiation. So it was kind of a disconnect that the hepatocellular carcinoma tumor in general was very radiosensitive, but also its surrounding environment being within the liver is also preclusive. So it wasn't until the advent of modern techniques that we were able to do stereotactic treatments and more ablative focus treatments in the ability to treat these tumors. So here's an example of what would be a more old-fashioned radiation technique with a two-beam arrangement delivered through the anterior and posterior angles of the patient. And you can see on the right the dose cloud of radiation with the red and green being the higher dose of radiation, that everything in between those two beams is getting the full dose of radiation. The spinal cord, a large portion of both of the kidneys, a large portion of the liver, as well as some of the stomach. And it's not very targeted, it's very crude, and that limited the ability to give meaningful radiation dose, and it also led to more toxicity. But like I alluded to, we have more advanced radiotherapy techniques, and I'll focus today more exclusively on stereotactic radiation, specifically stereotactic body radiotherapy. It's also known as stereotactic ablative radiotherapy, SBRT or SABR. Those are interchangeable terms. Another term that's often used is stereotactic radiosurgery or radiosurgery. That is also a synonymous term. What that means is that we use stereotactic coordinates to isolate the tumor in 3 planes. We use a multiple beam arrangement or arc therapy to be very conformal with our dose distribution. We use strict motion management and image guidance to have 2 millimeter accuracy. And with all of that, we are able to deliver more ablative doses of radiation. So here I've listed a conventional course of radiation, 50 gray in 25 fractions or 25 treatments at 2 gray per fraction. That gives, through some radiobiologic calculations, a biologic equivalent dose of approximately 60. When we deliver SBRT type doses, below is 50 gray in 5 fractions. That's a conventional SBRT type dose with 10 gray per fraction, and a biologic equivalent dose which is 40% higher at 100. So that 100 BED is kind of our radiation oncology benchmark for an ablative tumor treatment. So we're able to deliver that dose quite easily to the liver with not much issues in toxicity. So in addition, the radiation with SBRT is more outpatient, it's quick, it's convenient, it's cost effective. We deliver this radiation within 1 to 2 weeks as opposed to a conventional old-fashioned course of 5 to 6 weeks. So here's an example of an SBRT treatment. On the top left plane we have our tumor isolated with gold fiducial markers. We have outline of the tumor volume with margin for setup variability. In the middle plane we have the multiple beam arrangement targeting that tumor. On the right plane we have the dose cloud showing the red high dose of radiation with very limited low dose spill. And then below we have our daily onboard imaging. So we can plan this radiation very accurately, but we also have to be able to line up on a day-by-day treatment aspect. And so what the patient will have is on the treatment table a cone beam CT scan, which is done with 4D motion management, and we're able to kind of isolate that tumor in real time to target and hone in on those gold fiducials to deliver the treatment very accurately. Here is yet another example of an SBRT treatment targeting another liver lesion, much in the same way I previously showed. Here is yet another depiction of an SBRT treatment, only this time using a volumetric modulated arc therapy technique, which enables a continuous arc of radiation treatment being delivered around the patient in real time, which enables even more precision and conformal dose distribution. You can see the dose cloud in the top two right panes, and then as well below their corresponding cone beam CT imaging showing the tumor localization at the time of treatment with gold fiducials being placed. So with all of those different SBRT treatment plannings that I showed, I'd like to show this slide as well, which shows the kind of variability and breadth of different tumor locations that we can treat. Medial, inferior, superior at the dome. There's no one location that's kind of off limits for SBRT, but there are some technical limitations when tumors close to bowel, when patients have erratic breathing, or numerous other kind of technical challenges. But lo and behold, being part of that kind of multidisciplinary treatment approach, we can fill a role in treating some of the harder to reach tumors. So one of the limitations with radiation is the underlying cirrhosis, and the degree of that being challenging to spare functional hepatic parenchyma. So additionally, in addition to advanced targeting and motion management and daily image guidance, we also do functional treatment planning with our cirrhotic patients to map out the functional liver. This is an example of a SPECT CT scan used for that functional treatment planning to highlight the areas of active hepatic function. And when we plan our radiotherapy with this functional treatment planning, we're able to more accurately spare the functional hepatic parenchyma and target our beams in a way that takes advantage of the cirrhotic morphology and the patches of less active liver. And the outcomes for SBRT are pretty good. The local control, like I said, it's a very radiosensitive tumor, is upwards of 80 to 90% at 1 to 3 years, depending on which kind of study you've read, with kind of limited toxicity and very limited progression of Child-Pugh scores. And radiotherapy and SBRT compares fairly well with some of our other liver-directed therapies. Here's some work from the University of Michigan comparing SBRT to percutaneous ablation and TACE, showing very similar, if not slightly better outcomes in comparison. But, lo and behold, I am hesitant to put up a slide like this in a presentation where I've kind of hammered home the complementary treatment modalities as well as the multidisciplinary team approach. Most of the hepatocellular liver-directed therapy data, in my view, is somewhat biased. When you read a radiation therapy authored article, it's oftentimes biased towards SBRT, just as some other competing modalities may be. And so I don't put up this slide to contend that SBRT is better than RFA or TACE, but to say that it is comparable and in the right setting, a very viable option. Now, most of the tumors that I showed us treating earlier were kind of small, discrete 2, 3, 4 centimeter lesions, and oftentimes those are also amenable to things like selective TACE or percutaneous ablation or even hepatic resection. But where does radiation fall in when we get our kind of massive HCCs or our large HCCs? We can still do stereotactic techniques with the same kind of SBRT techniques techniques are, same SBRT techniques, aside from that we oftentimes have to fractionate a little bit more. Instead of 5 fractions, we have to protract the fractionation to be somewhat more gentle on the liver and the body, into 15 or 20 fractions. Oftentimes we will add things like radiosensitizing TACE and do radiotherapy as a boost to that, as well as oral capecitabine. In addition, we use advanced treatment planning techniques with IMRT and VMAT to shield the adjacent organs, such as the uninvolved liver, stomach, colon, from the tumor, and deliver a very ablative dose to the necrotic core of the tumor. But still, as good as we are getting at treating these liver tumors with radiotherapy, there's still quite a lot of room for innovation. And one of the next levels of innovation for hepatocellular carcinoma and radiotherapy is using MR-guided radiation therapy. And this slide on the right kind of shows a particular kind of evolution of radiation, and showing over time our performance and how we have gained the ability to treat tumors more effectively as technology has advanced over the decades. We started, as I alluded to earlier, with very crude radiation techniques with very archaic imaging by today's standards, to advancing our radiation treatment devices with multi-leaflet collimators and SBRT and intensity modulation, as well as 3D CT. And now our next line of performance is to use the extra precision of MRI to better guide our therapy. Not only guiding our therapy with daily imaging being better, but also guiding our therapy with adaptive treatment planning in real time. So one of the true benefits of MRI-guided therapy is that we can get a real-time image at that time and customize the radiation treatment plan on a day-by-day basis to really conform the radiation to the tumor and avoid the organs at risk. So on the left is an example of an MRI LINAC, and below is our MRI LINAC at Allegheny. It's, believe it or not, harder to get in there and take a picture with the magnet than you would think. So this is a screenshot from one of our monitors. So that was the best I could do so far. And here's a reference for further reading on MRI-guided radiation therapy if anyone has some interest in that. These radiotherapy techniques can be used with other histologies, including oligometastasis or cholangiocarcinoma. However, we're going to center our talk on hepatocellular carcinoma, so we won't touch base on those today. But SBRT can also be combined with our other modalities. So I've alluded to this multidisciplinary approach, and oftentimes we'll use multiple modalities in the same patient to achieve our ultimate goal of downstaging for transplant, of bridging to transplant, or definitive treatment. Radiotherapy has been successfully and safely delivered as a combined modality with radioembolization in Y90. And here is a paper from Sinai in New York showing a very good safety profile of doing radiotherapy in Y90 in combination with highly effective local control. SBRT can be combined with transarterial chemoembolization in a quite synchronous way. There is a synchrony between the radiosensitization of the chemotherapy given to the tumors, followed by SBRT boost, which can be quite effective. Just kind of highlighting the team-based approach that I've kind of mentioned so often in this presentation, that interventional radiology and radiation oncology can be kind of a great marriage of treatment approaches in a collaborative way to achieve very good outcomes. And very good results with TACE and radiation. As this paper has showed, the combination of TACE plus SBRT as a boost to TACE showed significant improved progression-free and overall survivals when you compare that to standard of care sorafenib alone. So, the treatment can be quite effective and very limited toxicity. But I'd be remiss to mention SBRT and hepatocellular carcinoma without alluding to the era of immunotherapy as well. And as we've seen immunotherapy having more effect in hepatocellular carcinoma, the question then remains with this synchrony of immune therapy and SBRT and how that marriage can come together as well. And there are numerous institutional trials ongoing with the combination of immunotherapy and SBRT as a synchronous combination of treatment modalities, but the data is evolving. So in conclusion, I think our highlights are that radiotherapy plays a niche role in the treatment of hepatocellular carcinoma, both in the bridge to transplant and definitive settings. It is a complementary therapy that works well with our multidisciplinary team-based approach, including our surgical oncology, medical oncology, and interventional radiology colleagues, and that thanks for having me.